Din sa ano po na pagawas.
My question Afternoon. Good afternoon, everyone. Is the audio clear naman? Both in Zoom and here sa live? Okay naman. So we'll be starting the event now. So good afternoon, everyone. My name is Rich, and I'm a first year Ophtho resident, and I will be the host for today's institutional conference, brought to you by the QMMC Department of Ophthalmology. So before we begin, may we have Dr. Pamela Chan to lead our opening prayer. So maybe ask everyone to stand up.
Let us put ourselves in the holy presence of the Lord. Heavenly Father, we come together asking for your presence among us. Guide our thoughts, words, and actions. As we engage in this afternoon's conference, may it be a fruitful and meaningful discussion. Through this, may we be instruments of your wisdom and grace, and may it inspire us to continue to contribute to our community and serve our patients better. We pray this in your holy name. Amen.
Let us all stand by and sing the national anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, elas na sinakanan, alam ng puso, sa titik mo'y buhay. Lumang hinina, tuya ka ng magiging, sa manlulubi, di ka masisingin, sa nagatang tugog sa simoy at sa langit ng bagaw, ay hinatang tula, tawid sa pagkayang minamahal. Ang matawad ay nabuhay na nagiging, ang ituwing na talo niya, kailan pa may magiging. Luwag ang araw ng maraming pagsinta, buhay langit sa piling mo. Ang ligaya ng pagkay mag-aami, ang mamatay ng dahil sa'yo.
May I ask everyone to be seated? Before we begin, may we have our department chair, Dr. Lawrence Morlunpe, for the opening remarks to grace today's event.
Good afternoon. Department of Ophthalmology. So masaya kaming i-host itong institutional conference sa buwan na ito. Actually, dapat nung ano ba ito July 25, kaya pinagsara tayo ng bukas. So ang topic natin for this afternoon, thyroid eye disease. Isang napakahalagang condition na siguro madalas natin hindi na-recognize. Pag may kumutang pasyente sa clinic natin na pinaka-problema ay lumalaki yung matanda, kahit hindi sila galit. So malamang sa hindi, ano ito, thyroid eye disease. Ito kasi yung pinaka-pangkaraniwan o common cause proptosis o yung pag-usli ng mata at ng opening ng mata. So, project kapitary ng line natin mga speakers linahon, try na sa kanila homegrown. So, dito sila tapos ng kanilang training sa ophthalmology, tapos pumunta sila sa further training sa ibang centers, locally at sa abroad. So makasama din natin ang colleagues natin from the different departments. Katulong natin sa pag-manage dito mga patients from ENT, from radiology, from internal medicine. So, ayun. So, thank you sa pagpupunta nyo. I know you have a busy schedule. So, sama-sama tayo natuto ngayon tungkol sa thyroid disease. Sana lang sumigla po na yan yung departments. Kasi yung mga kaso na ito, ay multi-specialty talaga. Also, pag-rin sa atin. Thank you again.
Thank you, Dr. Beth, for the opening remarks. So, before we begin with the lecture series, we will be having a short test brought to us by the current or method of the class 16 to test what we already know and later on gauge what we will be learning from today's event. So, may we call Dr. Beatrice Rivas to facilitate the
Please, everyone. So before here, having a short presentation, so we can use our phone, we write our answers now. And then after the lecture, we'll go on with the question to speak of what we already know and what we have learned. So first question would be, true or false, we can have thyroid eye disease with normal thyroid function level. Question number 2, what is the most common kind of thyroid eye disease? A, proptosis, B, liver rash, C, orbital pain, and D, eye redness. Which is not included in the criteria for diagnosis. A, immune-related thyroid dysfunction. B, typical ocular signs. C, radiologic evidence. Or D, exposure to cigarette smoke. Which is not included in the criteria for diagnosis. True or false? PEB can present with unilateral or bilateral proptosis. The following are complications of PEB when left untreated except A, optic neuropathy, B, exposure keratopathy, C, diplopia, or D, none of the above. So the following are complications of PEB when left untreated except true or false. In PEB, men are more affected than women. In PEB, men are more affected than women who are which ocular muscle is most commonly affected in PEB? A, superior rectus, B, inferior rectus, C, medial rectus, or D, inferior oculus. Which extraocular muscle is most commonly affected in PEB? Which modifiable risk factor is most consistently linked to developing or worsening of PED? A, alcohol consumption, B, Next one. What is the first line of treatment for TED? Please have preparing IVs steroids, methotrexate, series of demand, or gene surgery. What is the first line of treatment for TED? Last question. What qualifies as severe TED? A. Patient cannot close his eyes. B. Patient cannot see colors and fails to issue harmless. C. Patient has large puffy eyeballs. Or B. Patient has elevated thyroid hormones despite medication. So what qualifies as a severe TED? We'll check their answers after. Wow, that was a challenging retest, in my opinion. I think that we have the following lecture series to learn from, and hopefully improve our scores later on. Series, they're giving her insight on how to identify thyroid eye disease. We have one of our previous residents from the Department of Ophthalmology from the years 2014 to 2017, and she had her fellowship at the University of the Philippines, Philippine General Hospital, and one of our current consultants at the Department of Ophthalmology, under the section of Orbit and Oculoplastics. Without further ado, it's my honor to present to you Dr. Clarice Sabriatan.
Good day, I am Maria Clarissa Sobriatan, a consultant of the Orbit and Oculoplastic section of the Department of Ophthalmology, and I will be giving a brief overview of thyroid eye disease. The following are the objectives of my lecture. And here is the outline of my presentation. Thyroid eye disease, or TED, is an autoimmune inflammatory disorder associated with thyroid disease. It is the most common orbital disorder in adults and most common cause of unilateral or bilateral axial proptosis. Women are more commonly affected, and smoking is the most important risk factor identified. In TED, there is loss of immunological tolerance to the thyroid-stimulating hormone receptor, edema, accumulation of glycosaminoglycans and collagen, and adipogenesis cause enlargement of both extraocular muscle and orbital adipose tissue. Diagnosis of TED is based on first, presence of concurrent or recently treated immune-related thyroid dysfunction. Among patients with TED, approximately 90% have Graves' hyperthyroidism, 1% have primary hypothyroidism, and 3% have Hashimoto's thyroiditis, and 6% are euthyroid. In 20%, diagnosis of TED and hyperthyroidism are made at the same time. In 60%, eye disease occurs within 1 year of onset of the thyroid disease. Second, presence of orbital signs like the following. Two most common signs of TED are upper eyelid retraction, found in 90% of patients, and proptosis. Upper eyelid retraction is produced by levator Mueller muscle inflammation and fibrosis, or bilevator complex overaction secondary to inferior rectus restriction. Proptosis is caused by expansion of the orbital fat and/or the muscles. Lastly, radiographic evidence of fusiform muscle enlargement. This criteria for the diagnosis of TED was proposed in 1995. However, I still find this criteria very useful in my practice whenever I deal with TED. In a study by Bartley and Gorman, they noted that over 90% of patients with TED had eyelid retraction, and this, together with any of the four signs, thyroid dysfunction, exophthalmos, optic nerve dysfunction, and EOM limitation, pointed to a diagnosis of TED. If, however, eyelid retraction is not present, thyroid dysfunction, whether hyper or hypo, in conjunction with any of the three signs, exophthalmos, optic nerve dysfunction, and EOM involvement, a diagnosis of TED can be made. An appropriate assessment of both activity, referring to the inflammatory process, and severity, referring to the quality of life or the risk of vision loss, of the disease is crucial to determine the appropriate management. The presence of multiple features of inflammation like pain, redness, and edema usually signifies active disease. The Clinical Activity Score, or CAS, is used to determine activity of TED, and it is based on classical signs of acute inflammation. This was proposed by the European Group of Graves' Orbitopathy, or UGOGO, and is used by many orbit subspecialists. 1 point is given for each parameter that is present in the patient, and a total score of at least 3 out of 7 signify an active disease. It is important to be familiar with the natural course and prognosis of TED, as this determines the appropriate management. TED follows a biphasic course. Active phase generally lasts for 18 to 36 months, followed by a stable or inactive phase. On the diagram on the right, the inflammatory phase can be represented by a house fire. The firefighter represents immunomodulatory therapy, employed during the active phase with the hope of reducing collateral damage, shown by a displacement of the upper untreated curve to the lower treated curve. Once disease has stabilized, reconstructive therapy may be considered, represented by the construction worker. In summary, thyroid eye disease, or TED, is an autoimmune inflammatory disorder associated with thyroid disease which affects ocular and orbital tissues. Diagnosis of TED is based on concurrent or recently treated immune-related thyroid dysfunction, typical orbital signs, and radiographic evidence of TED. It is essential to differentiate between the concepts of activity, referring to the inflammatory process, and severity, refers to the quality of life or the risk of vision loss. TED follows a biphasic course, active phase, followed by a stable or inactive phase. These are my references. Thank you for listening.
Thank you for that very informational lecture, Dr. Subiatan. So even as an ophthalmologist in training, I've learned a lot from that very concise lecture. So before moving on, are there any queries from the floor or the online audience? Okay, so now that we already know how to identify thyroid eye disease, let's move on by discussing its natural course of disease through a case presentation. So we have our third year ophthalmology resident and the current team leader of the Orbit and Ophthalmoplastic team, Dr. Ian Cabello, to present the case, and will later on be supplemented by the section head of our Orbit and Ophthalmoplastic division, the Department of Ophthalmology, Dr. Ian Cabello.
Hello. Good afternoon, everyone. I am Dr. Ian Cabello, current third-year resident leader of the Oregon and Ophthalmology speaking. I'll be presenting two cases of thyroid eye disease we've seen in the clinic, which are broadcasted by their activity. Our first case is patient KE, a 52-year-old female who came in for bulging of her right. 2 months, 2 months prior, the patient noted asymmetry of her eyes with noted bulging of her right. So therefore, were no prior trauma, no blurring of vision, no eye pain or redness. Furthermore, she denied any palpitations, tremor, easy fatigability, or human problems. She is a known hypertensive and wears spectacles of undergo refraction. She is a non-smoker, but importantly, she claims to be exposed to secondhand smoke in the household. Her family history at this point is not clear. On physical examination, the patient had good vision at 2020 for both eyes with normal intraocular pressures. Her extraocular movements were full and equal, with no pain on movement. Grossly, on the right, as you can see in the photo, we note lid refraction as the upper lid margin lies tangential to the superior corneal limbs with lack of alpha. So in the picture below, generally the rest of the examination were unremarked. Upon further workup, her thyroid function tests were outside their normal values with elevated FP3 and FP4 and low TSH. Through this pertinent findings, we'll be managing the patient forward as a case of thyroid, as a case of a mild inactive thyroid eye disease of the right eye, exposure keratopathy of the right eye secondary to lack of thalamus and hyperthyroidism as managed by eye. So for our second case, we have patient AC, a 40-year-old female who came in our clinic for eye pain. So here you'll see the contrasting activity of both thyroid eye cases. So this case, 4 months prior, patient noted gradual bulging of both eyes with associated blurring of vision, eye pain, and tinnitus. So this persisted until 2 months prior. The patient was advised to have thyroid function tests done, showing normal results. So 2 weeks prior, the initial consult, the patient noted that the eye pain became more constant, with increasing in the blurring of vision, now with associated eye pain. Then few hours prior to consult, the patient sought another check-up with another ophthalmologist and was subsequently referred for an institution for subspecialty management. Moreover, the patient noted episodes of easy fatigability, palpitations, and constipation during the history of present illness. She had no prior known comorbidities or any diagnosed thyroid disorders prior. She wears glasses with undergo refraction. And it's important to note also that she is a heavy smoker of 20 years. On physical examination, the patient had decreased visual acuity at 20/70 on the right eye and 10/400 on the left. Color perception is also poor on both eyes based on Ishihara testing. Intraocular pressures were within normal limits, however, extraocular movement were mildly limited in some cases. Grossly, both eyes are seen here in the bigger photos. In the bigger photos, with the refraction having scleral flow, superiorly and inferiorly. There is rhabdosis and lack of thalamus as well. Both lids, caruncles, and conjunctiva were all swollen, and their erythematous or hypertrophic. Furthermore, due to the lack of thalamus or incomplete closure of the eyelids, there are corneal epithelial defects seen in the slit-lamp photos in the upper right corner. Upon imaging with plain cranial and orbital CT scan, in the first two panels shows an initial view of both soft tissue and bony window. How both the lateral and medial right eye muscles Um, Both eyes pointed by the dotted arrows are seen with a fusiform configuration with ligament muscle depth tapering along the tendons. On the next two panels, however, during the orbital view of the orbital apex, both soft tissue and bony window, showing crowding of the recti muscles along the apex or their common origin, and possibly compressing their adjacent tissue boundary. So moving forward, again, we'll be managing this case as an active and severe case of thyroid eye disease for both eyes, exposure keratopathy for both eyes secondary to lack of thalamus, to consider compressive optic neuropathy for both eyes and hyperthyroidism as mentioned.
Yeah. So actually, in those two cases, it's a good way of plan or of displaying to you how stark the difference, different types of thyroid eye disease can be. So the first case, so in the two cases previously shown, again, we see the stark differentiation. The first one noted change in appearance. So just change in appearance of the patient, while the second case presented with obvious signs of activity. So the spectrum of disease and PED can be very broad and wide, from subtle and almost undetectable to very severe that can be vision threatening. And we as clinicians may catch them at different times. That's why we presented these cases and initially showed you the overview of what thyroid eye disease is. In terms of intervention, it is the active part that we need to proactively manage, and appropriate referral to appropriate services should be carried out. So this random curve shows the biphasic pattern of presentation of PED, usually seen in the first 1 to 3 years or 6 to 18 months. And eventually it will reach a quiescent phase as shown in the graph. So although now new understanding of this elusive heterogeneous autoimmune condition that shows it waxes and it wanes, it can flare in indistinct phases. And even if one has reached a quiescent phase, there is actually still a 5% chance that activity may reduce. So it's lifelong. It may be driven by different external stressors that can actually worsen the disease, such as pregnancy, smoking, ocular trauma, and other comorbidities. So it's very important that we consider a system-based approach to the treatment and document the burden of disease to our patients. Because as you'll see later on, it really has a significant bearing in the patient's quality of life. I think when we showed you the other case, some people reacted because it can really be very devastating and morbidly disfiguring for these patients. So it's important we treat them properly with a multidisciplinary approach. So later we'll discuss that more in detail. Sorry, I just wanted to share this tool, especially for the non-ophthalmologists. So I came across this questionnaire which you, if ever, especially our internal medicine colleagues encounter these patients, maybe even our ENT colleague patients, it's just a 5-minute questionnaire. No? So just asking yes or no questions based on the patient's experience and also what the clinician sees. So actually, even if you're not ophthalmology trained, you will know which are the urgent referrals and which will just need a usual referral to an ophthalmologist. And maybe some of you encounter these patients can incorporate this in your practice. So we can share that if you want. Thank you so much for the comprehensive discussion with Dr. Cabell and Dr. Carunan. So it's very beneficial for us to know how thyroid eye disease is laid out in order for us to manage our patients with the disease accordingly. So now the floor is open again for any queries from the floor and from the online audience.
So since we already tackled the natural course of illness of DED, we already know that management of the disease is approached in a multidisciplinary manner. But who exactly is involved in the treatment of DED? So to discuss this further, we have two of our consultants again from the Department of Ophthalmology or within Ophthalmology Division. We have one of our previous residents who graduated his residency here at UNMC and had his fellowship at Asan Medical Center in South Korea. And we also have one of our consultants who graduated his residency here at UNMC, but also had his fellowship at Sydney and Sydney Medical Center in Australia. So it is my honor to present to you Dr. Ulysses Gap and Dr. Marla Pancho to present us the management of DED.
Hi, good afternoon. Am I audible?
Yes.
Okay. So, we've heard about the basics of thyroid eye disease and the principles for the general physicians in identifying TED. So for the next 10 minutes, allow me to discuss the multidisciplinary management of TED, especially for early and moderate to severe TED. So good day, my name is Joseph Yap. I'm a graduate of the Ophthalmology Residency Training Program of QMMC, and I'm currently a visiting consultant for the department. So Graves' orbitopathy, as we've learned from Dr. Sabrillo, is the main extrathyroidal manifestation of Graves' disease. And the choice of treatment should be based on the assessment of the clinical activity and severity of GO. Early referral to specialized centers is fundamental for most patients with GO, and risk factors include smoking, thyroid dysfunction, high serum levels of thyrotropin receptor antibodies, radioactive iodine treatment, and hypercholesterolemia. It's important to remember these risk factors because their presence will determine whether supplementary treatment modalities are indicated for particular patients. I'm sure this bears no repeating, especially to our seasoned endocrinologist colleagues, but every patient with Graves' disease should be screened for TED, as patients with Graves' disease have a much higher risk of developing TED. According to the ATA and ETA consensus statement, all Graves' disease patients should be screened for TED at every specialist visit. So keeping a watchful eye out for ophthalmic clues can help the Graves' disease specialist consider a referral to an ophthalmologist, particularly an orbit and oculoplastic specialist, for a comprehensive eye exam. So these clues include signs and symptoms like proptosis, lid retraction, diplopia, pressure or pain behind the eyes, photophobia, redness or swelling of the conjunctiva or eyelids, excessive tearing, dry eye, foreign body sensation, or color and vision loss. So if you notice, the signs and symptoms don't just include the criteria mentioned earlier for calculating your clinical activity score. So how to co-manage thyroid eye disease. In the last 30 years, we've seen a reduction in the incidence of GO in Graves' disease patients, as well as of its severity when present. So this secular trend is multifactorial in origin. For one, it could be due to the decrease in smoking habits, earlier diagnosis, and better control of thyroid dysfunction. Also, it could be due to the improved interaction between endocrinologists and ophthalmologists, leading to earlier diagnosis and treatment. So it's now well understood that mild GO can progress to a more severe disease requiring expert advice and guidance for a general management plan. The endocrinologist plays a vital role in monitoring your TSH or TSH receptor antibody, your TSH, free T3, and free T4. So they're frequently the first in line to assess Graves' disease patients, which is a good opportunity to look for and ask about any present or past eye symptoms. Occasionally, ophthalmologists, in particular your oculoplastic surgeons, are the first to diagnose thyroid eye disease. Next slide, please. So, especially in patients who notice their eye symptoms earlier than the systemic symptoms of Graves' disease. For initial consults, it's important that ophthalmologists conduct baseline eye exam and in subsequent consults, evaluate how the patient's TED is changing over time. It's important to develop a treatment plan for the patient and decide how often the condition should be checked, collaborating with other specialists to manage the condition. For mild and active GO, every effort should be made to remove risk factors in order to prevent de novo occurrence and/or progression of GO, regardless of the clinical phenotype. So ocular surface inflammation and dry eye are very frequent in Graves' disease patients, regardless of the presence of overt Graves' ophthalmopathy. Several factors contribute to the drying of the eye. Increased width of the palpebral fissure, exophthalmos, blink rate, lid lag, lagophthalmos, poor Bell's phenomenon can all lead to restrictive elevation deficit and an altered tear film osmolality. So local treatment with artificial tears during the day and ophthalmic gels or ointments with a possible taping of the lids at nighttime are recommended to GO patients. Patients living in selenium deficient areas can benefit from oral selenium supplementation. The map on the right shows selenium distribution at a global scale. So world regions naturally enriched in selenium appear in red, whereas pink areas correspond to regions with naturally low selenium concentration, and white areas correspond to regions with unknown concentration. And a study by UP showed that regardless of the iodine status, actually a third of our population had blood selenium levels below the arbitrary cutoff, indicating the prevalence of selenium deficiency in the Philippines, especially in children. If RAI treatment is selected to manage Graves' disease patients, low-dose oral prednisolone prophylaxis is needed, especially if risk factors coexist. Next slide, please. So general recommendations include smoking cessation, treatment of the thyroid dysfunction, preferably with antithyroid drugs, especially if with risk factors for deterioration or progression. So what are these risk factors? They include clinically active GO, smokers, severe or unstable hyperthyroidism, or a high TSH receptor antibody status or titer. So in treating these patients, it's important to avoid iatrogenic hypothyroidism, as this too may lead to Graves' ophthalmopathy symptoms. Next slide. So when radioactive iodine is initiated due to the presence of these risk factors, oral pred prophylaxis should be given to prevent progression. And oral prednisolone are usually started at 0.1 to 0.2 milligrams per kilogram per body weight, tapered and withdrawn after 6 weeks for low-risk GO patients, and 0.3 to 0.5 milligrams per kilo body weight, tapered and withdrawn after 3 months for high-risk patients. So local treatment for mild and active GO, once again, they include artificial tears and ophthalmic gels. And on top of that, the systemic adjunct includes the selenium supplementation for 6 months fasting intake. Now, if quality of life is markedly impaired, low-dose IMT should be discussed for active GO cases, while rehabilitative surgery following extensive counseling and shared decision-making should be discussed for inactive GO. So this is where the Rundle's curve presented earlier comes into play in the reconstructive or constructive phase in the past the inflammatory or active phase. Next slide, please. So there are several quality of life questionnaires available that assist physicians in assessment of marked impairment in GO patients. So this is a widely used quality of life questionnaire by the European Group on Graves' ophthalmopathy, and it focuses on usual activities and the degree of limitation a patient feels due to their thyroid eye disease, like as simple as walking outdoors or moving around the house, to specific questions with regards to thyroid eye disease in general, such as their personal appearance. Next slide, please. In terms of rehabilitative surgery indicated for inactive or residual Graves' ophthalmopathy manifestations, it follows a proper sequence, beginning with orbital decompression as depicted in the picture on your left. Highlighted in blue are the bones usually removed. So it's usually the medial end floor or a balanced decompression, which is the medial and the lateral wall. And squint surgery and eyelid surgery or blepharoplasty may also be advised. For moderate to severe active Graves' ophthalmopathy, antithyroid drugs are preferred when managing Graves' hyperthyroidism, and IV glucocorticoids are more effective and better tolerated than oral glucocorticoids. So a cumulative dose of 4.5 grams IV methylpred in 12 weekly infusions is the optimal regimen, and higher cumulative doses not exceeding 8 grams can be used as monotherapy in most severe cases and constant or inconstant diplopia. GO patients with evidence of viral hepatitis, significant hepatic dysfunction, severe cardiovascular morbidity, uncontrolled hypertension should not be administered IV glucocorticoids, and diabetes should be well controlled before starting treatment. So all of these emphasize once again that the importance of multidisciplinary nature required in the treatment approach of Graves' ophthalmopathy, and treatment should only be applied in experienced centers that can manage potentially serious adverse events. Second-line treatments include a second course of IV methylpred subsequent to careful ophthalmic and biochemical evaluation. Oral pred or prednisolone combined with either cyclosporin or AZT, orbital radiotherapy combined with oral or IV glucocorticoids, and teprotumumab, rituximab, or tocilizumab, which are not that accessible in our Philippine context. There is increasing evidence suggesting the benefits of orbital radiotherapy in Graves' ophthalmopathy when combined with systemic corticosteroids. However, a prospective RCT that directly compares the IV glucocorticoid monotherapy versus the IV glucocorticoid combined with orbital RT is not yet available. So as a summary, for mild GO, there are several aspects of the management that serve as a gateway for other subspecialists or other specialties to step in, whether it be through the active management of thyroid dysfunction with antithyroid drugs, or as simple as encouraging smoking cessation. The significance of a multidisciplinary approach to managing GO cannot be overemphasized. This holds true also for the first line. Next slide, please. This holds true also for the first-line treatment of moderate to severe and active Graves' ophthalmopathy. And second-line treatments of moderate to severe and active GO, where orbital radiotherapy now becomes a potential treatment strategy. So all these points can be summarized in the 5-step approach advocated by the American and European Thyroid Association Consensus Statement Thyroid Eye Disease, which are to diagnose Graves' disease accurately, screen all patients with Graves' disease for TED at each visit, alert all patients with Graves' disease to the risk of TED, and to prevent TED development for progression, and to refer a specialist early. So this is, on your right, you'll see the Thyroid Eye Disease Early Warning Card, which is a public health intervention which was advocated or pushed for by the UGOGO and the ATA and ETA consensus statement. So this is distributed to all patients with Graves' disease so that they can keep an eye out for any subjective symptoms of Graves' ophthalmopathy and subsequent consult with an ophthalmologist for proper screening and evaluation. To conclude, early referral to specialized centers is fundamental for most patients with GO. And primary care physicians, general physicians, internists, endocrinologists, general ophthalmologists are all capable of managing the mildest cases without risk factors, of course, unless progression occurs. So with that, thank you for your kind attention. And yes, thank you once again.
Thank you so much for listening. We now call on Dr. Marco Mancho to discuss on the management of the
There. Can everyone hear me? Hello. Yeah. Yeah. So, good afternoon, everyone. My name is Marlo Cancio. So, I graduated from Sydney Eye Hospital for my fellowship training. So, I'm here to discuss the next and probably the final part of the management of thyroid eye disease. So, majority of the patients that we see are actually managed medically, as what was discussed by Dr. Lolong Yap. But this one is for sight-threatening thyroid eye disease. So this is different from the severe thyroid eye disease. So moderate and severe are categorized together, and this is the also known as the very severe thyroid eye disease. So sight-threatening thyroid eye disease occurs in 1 to 2% of cases, so it's very rare, and it is considered an ophthalmologic emergency that should be treated immediately. So the loss of vision can be due to compressive optic neuropathy, or also known as dysthyroid optic neuropathy, where the optic nerve is compressed by the enlarged extraocular muscles of the eye. Another way for you to lose your vision is if you have severe corneal exposure breakdown, such as if you have corneal ulceration or very severe corneal exposure keratopathy. And the last one is globe subluxation, which causes the stretching of the optic nerve, leading to acute optic neuropathy. Next slide, please. So some of the signs and symptoms of a sight-threatening thyroid eye disease includes they include the decreased vision, visual field defects, optic disc swelling, and the most common is the reduced colored vision, which occurs in almost 100% of the patients. Severe corneal exposure breakdown can be due to the inability to fully close the eyelids, or what we call lagophthalmos, and this can lead to corneal ulcer and infection. And the third part is the globe subluxation, or the popping out of the eyes, which again causes the stretching of the optic nerve, leading to acute optic neuropathy and visual field defects. Next. Next slide. So based on the UGOGO guidelines, the first line treatment for sight-threatening thyroid eye disease is high-dose IV glucocorticoids that are proven to be effective in about 40% of dysthyroid optic neuropathy cases, or DON cases. So generating improvements in visual acuity and avoiding or postponing subsequent orbital decompression. So a small RCT showed that in dysthyroid optic neuropathy patients, immediate decompression did not result in a better outcome compared to IV steroids given first. And visual deterioration 2 weeks after initiating medical therapy is also predictive of a poor response to IV glucocorticoids, and it warrants early consideration for orbital decompression. Next slide. So orbital decompression in the active phase, it reduces intraorbital pressure and proptosis by removing bony orbital walls with or without removal of the orbital fat. So for non-ophthalmologists, it's basically you're creating extra space for the optic nerve to breathe, because the enlarged extraocular muscles, as you know, the orbit is a very small space. So if the muscles enlarge, it's just gonna keep compressing on the optic nerve. So you want to create more space by shaving off the orbital walls, with or without removal of the orbital fat, to allow the optic nerve to breathe. And approximately 2 millimeters of proptosis is reduced per orbital wall removed and orbital fat excision. So for dysthyroid optic neuropathy, the problem is apical compression of the optic nerve by the swollen EOMs. So this is relieved by decompression of the deep medial and inferior orbital walls through a transcaruncular or endoscopic approach. So this is important because if you just shave the more anterior part, it's not really going to work because the optic nerve is located more posteriorly. Visual improvement may also be noted within days of the procedure. However, like with any other surgery, there are risks involved with the surgery, such as diplopia or strabismus, CSF leak, intracranial hemorrhage, blindness, or cheek numbness. And for severe corneal breakdown, temporary measures can be used to treat the cornea, including suture tarsorrhaphy, where you suture the upper and lower eyelids together, keep the eyelids closed, gluing, or antibiotics. And also, it is important to distinguish compressive optic neuropathy and stretching of the nerve due to subluxation, because a stretched optic nerve does not really respond to medical therapy. So if he gives steroids for a patient with globe subluxation, it's not going to work. So you have to do surgical decompression to reduce the proptosis and to improve the vision. So I'm going to share with you a case that we handled in Australia. So this is a Caucasian woman, 51-year-old female, presented with a sudden and severe blurring of vision of the right eye, bulging eyes, orbital pain, and decreased color vision. So on physical examination, she had ocular restriction, elevated intraocular pressure of the right eye, and RAPD. But when you look at the optic disc, they look normal. Orbital CT scan showed bilateral proptosis and enlarged recti muscles. And you can see on the lower photo of the CT scan, there's an apical compression already of the right optic nerve by the extraocular muscles. She also presented with, she also
Secretary yung ano niya, inhaler yan.
she also presented with visual field defects, particularly in the right eye. Significant. Hello. Yeah, so at this time, she was assessed to have this thyroid optic neuropathy in the active phase. Next slide. So in keeping with the updated YGOGO guidelines, we gave high dose of 1 gram IV methylprednisolone for 3 consecutive days. And next slide. So after the first cycle of the high dose of IV methylprednisolone, significant improvement of symptoms were noted, indicating good response to the therapy. But if you follow the YGOGO's algorithm, another cycle of 1 gram IV methylprednisolone was given a week after the first cycle. And at this point, the patient actually felt normal, that she was back to normal. She had good vision, she felt good, no orbital pain, etc. Next slide. However, 2 weeks after the cycle, she came back again due to worsening of symptoms. And she now presented with bilateral decreased vision, redness, and eye pain, and a CAS score of 8 out of 10. So, next slide. Here are CT scan images. So on top, this is the one, the images before presentation in the center. And the ones at the bottom were the repeat CT scan after 2 cycles of the high dose IV methylprednisolone. And as you can see, despite giving 2 cycles of high dose IV methylprednisolone, she still had significant or even larger extraocular muscles in both eyes this time, and causing apical compression bilaterally. Next slide. So because medical therapy with high-dose steroids did not work, or only with partial response, following the guidelines, an urgent orbital decompression of the medial and inferior orbital walls of the right eye were done via the endoscopic approach. Next slide. So here is a day 1 post-op photo of the patient. So you can see that the vision significantly improved from 690 to 618 with reduced right eye proptosis, and no orbital pain or doubling of vision was noted. Next slide. So this patient is actually an interesting case because 2 weeks post-op, she still remained asymptomatic, but the left eye was already showing signs again of this thyroid optic neuropathy. So it was all the left eye was now planned for surgery. But going back to the right eye, as you can see in the orbital CT scan, you can see that the medial wall and the floor were enlarged. And you can see the recti muscles and orbital soft tissues are herniating into that extra space that we created to allow the optic disc, the optic nerve to finally breathe and restore the vision. So it is also important to note that after doing orbital decompression, you should also continue with your oral prednisolone to help with the inflammation. And this should be tapered down slowly in the coming weeks and months. Next slide. So in summary, for sight-threatening thyroid eye disease, there is a need for urgent referral to an orbit specialist. There is also a need for immediate initiation of high-dose IV methylprednisolone pulse therapy rather than doing immediate orbital decompression. And however, if medical treatment fails, then that's the time that you do urgent orbital decompression. And important is that there should be continued multi-specialty surveillance and co-management after the surgery because um, orbital decompression does not turn off the inflammation. So you still have to give your anti-inflammatory medications and continued monitoring with your endocrinologist and rheumatologist to make sure that the inflammation dies down so that to prevent any recurrence of or any worsening of the vision disabilities. Thank you.
Thank you so much, Dr. Kamish. So now that we have discussed the early management and urgent management of PED, we will now call on Dr. Rian Perdulan to discuss the chronic management.
So I think that just puts things into perspective about how broad this condition can be. So there's really the active phase where I think we should be able to catch it early and treat it early so that the residual effects is not as bad later on. Okay, so let me just show you. So this is going to be the outline of my discussion. Okay. So treating the active phase in a timely manner, as I mentioned, is known to actually shorten the inflammatory duration of this disease, as well as its residual side effects. So despite being able to give the right management, I still often say to my patients, we can't assure 100% return to your pre-PED state. And so this chronic and inactive phase remains to be tricky and the challenging part of the overall management of PED. So this is the many looks of PED. Once out of the woods for that risk of going blind, these patients still face a lot of challenges, both functionally and aesthetically. They may have persistently bulgy eyes, lid retraction that lead to severe dry eyes and irritation, misdirected lashes that can also lead to keratopathy and bad glares, and ocular misalignment with debilitating diplopia. Only until recently that a drug was developed to treat this inactive phase as well. So that's your teprotumumab. It's a monoclonal antibody that targets your IGF-1, but it remains expensive extremely. So it's around 400,000 US dollars to complete the infusion. So that's impossible. We're not going to get that here. So for the longest time, treating the chronic phase has become very difficult because no amount of steroids or anti-inflammatory medications and even radiation can treat these symptoms because already there's no more active inflammation. And even the aesthetic sequelae should not be taken for granted because this has an impact in these patients' quality of life and some can even lead to depression. So in the chronic phase of the disease, Okay, so in the chronic phase of the disease, there is still a number of things we can do for the patient in terms of surveillance. So from the perspective of the endocrinologist, it still boils down to controlling thyroid levels. As much as possible, we want to avoid hypothyroidism, which is also known to activate or tip the TED to a more severe disease. So of course, at the end, you always still aim for euthyroid state. For patients who remain to have the range levels, and RAI might be the best option, you have to refer them back to us because sometimes they need prophylactic anti-inflammatory because RAI triggers an inflammatory response because the thyroid antigens are a good stimuli for this activation. No? So we have to give steroids. Okay. So, and then of course, from the ophthalmologist's point of view, a number of surgical rehabilitation can be offered. So in this traditional sequence of surgical staging, so usually we offer surgery after 6 to 12 months of inactivity. So first, we address proptosis by orbital decompression. And in my opinion, the best approach is to do it combined with our ENT friends. No? So for proptosis, what happens here is the outward bulging of the eyes because of the overloaded volume in the orbit. So there is fat and muscle hypertrophy. So this is actually a patient who is still in the active phase, but this patient needed orbital decompression. So I'm showing her in this slide and how impactful this procedure can be for this kind of symptom. No? So this patient underwent bilateral balance decompression, which is basically removing both the medial wall and the lateral wall to allow fat to prolapse. No? So like what Marlo mentioned, the orbit is a confined space. So when things are growing inside, it compresses the nerve. No? So you have to allow it to go outside so that the nerve can breathe again. So I'll just show you. So this is what we did for the patient. Okay. Actually, this is courtesy of Dr. Harin because this is a collaborative effort. So through their endoscopic, so like I said, we work pretty well with the ENT for this. Through their endoscopic access, there is direct visualization of the medial wall. And in cases where we want to decompress as far back into the apex where the optic nerve is, so here, they have the best chance of getting there safely, especially now with the help of navigation-guided surgeries, they can easily access this space. So I'd like to thank and credit Dr. Peter Harin for this video that we did for this patient. So as you can see, they did a test to expose the medial wall, and now here you're already accessing the medial periorbital of the orbit. No? So this is the goal of this decompression. You want to lacerate the periorbita, that's the sort of wrap of the orbit, and you want to allow the orbital fat to prolapse. I'm going to fast forward this in the interest of time, but to show you how it looks like intraoperatively. So this is Dr. Harin doing the endoscope, and I'm the one doing the slitting of the periorbita to allow the fat to prolapse. So we want the fat to come out as much as possible up to this amount. Carefully making sure that you don't injure the recti muscle. Okay, so as you can see again. Okay, so that was the medial wall. And additionally, we also do a lateral decompression transcutaneously by creating these incisions to expose the lateral rim and drill out the superolateral orbital wall. So that's in this area and slightly more inferiorly in this area. And similarly, we also lacerate the periorbital to allow fat to prolapse as well as the lacrimal gland to this newly formed space. So just to show you how significant change this can offer our patient. So from this stage to this stage, actually this patient, when the resident asks, "Ma'am, pakit po yung mata." Ilang beses niya inulit. Because actually that's already the patient closing her eye. She can't really close her eyes because of the proptosis. Okay, so this is post day 5 after decompression. So we've actually decreased proptosis by 7 millimeters. So that's quite significant though. For her in terms of compressing the optic nerve, it drastically improved her vision. So initially she was just seeing black and white, but after the surgery, He said, "No, I can really see the color of your shirt, the color of your pants." So that's quite significant. Okay. So this is just another patient who we also did bilateral balance decompression already in the inactive phase. So for her, we achieved 4 milliliters of decrease in proptosis. So another problem in the chronic phase is strabismus. So this is where there is persistent ocular malalignment. It's actually one of the most difficult aspects in the management of these patients, probably next to this thyroid optic neuropathy. And that's why working well with our strabismus specialists, those who specialize in ocular alignment, is crucial in the holistic management of the disease. Okay, so we'd like to thank Dr. Macias. So yan yung samples of strabismus. So we'd like to thank Dr. Macias for this photos. No? So this is a case of severe ocular misalignment due to fibrosis and hypertrophy of the recti muscles that occur in these patients. So this is what we call composite photos that just show the alignment of the eyes in different ages. So again, just focus your attention on the center photo where the patient is actually looking straight ahead. Definitely this patient will see double all the time. Okay. Now, under the best hands, so of course we'd like to flex our strabismus section head, Dr. Macias, you can improve diplopia of these patients. So for this patient, he underwent recession with the release of contractures of the right inferior and right medial recti muscles and recession on adjustable suture of the left medial rectus. So with that difficult and challenging surgery, they were able to achieve ortho in primary position. So at least in the usual gaze of the patient, diplopia is significantly eliminated. And that really impacts a lot on the patient's quality of life. Okay, so now, the next is for the eyelids. Now, once proptosis and strabismus have been addressed, we now deal with the issues of the eyelid. So for example, this patient, initially you would not notice what is wrong with this patient because it can be very subtle. Especially with our dynamic eyelids, it always fluctuates. But these patients, they see their eyes every day and they know that that's not how they usually look. So in these cases, what happens is there's an overacting of the muscles that elevate the eyelids. And here, because it's not so severe, what we just have to do is release the Mueller's. It's one of the muscles responsible for lifting the lids by 2 milliliters. No? So there are other non-invasive techniques like Botox injections, triamcinolone injections, but most of the time they're not really that effective. So if it's persistent, the patient is very bothered, you can offer these procedures for them. So just to show you, no, in theory, what we do, we approach this posteriorly, we open up the conjunctiva, and we try to dissect to expose the Mueller's muscle. So we remove the entire muscle to allow the lid to go down by 2 milliliters because it said that this muscle is responsible for the 2 millimeters of lift. So this is the patient 1 day post-operatively. So actually what you want to look at is the white part here or the scleral show, which significantly decreased here. No? Yeah. So now these patients allow themselves to be photographed. So they always tell me, no, nagpapapicture na ako. So I guess that's a sign that you've made an impact on these patients. And lastly, the inward directed lashes. I think this is commonly unrecognized or under-recognized. So occasionally, and especially in eyelids of Asians, we have a considerable amount of what we call epiblepharon occurring with PED. So this is something we should have a key eye on. This is a result of the combination of lid retraction, proptosis, and fat hypertrophy that happens in PED. So what happens is it pushes the lower lid skin and subcutaneous tissue superiorly and will have a net effect of lashes drawn towards the eye. So what happens here is there's a lot of irritation. The patient will always say they're tearing and there's a lot of glare because the ocular surface is not smooth. So what you have to do is you have to put it back to its proper position by creating everting sutures. So this is called your modified Watts procedure. You make a subsidiary incision, you expose the orbicularis until the tarsal border inferiorly, and you put sutures at this level. So this suture is intended to evert the eyelids and evert the lashes subsequently so that it no longer rubs on the cornea of the patient. Okay, so in summary, TED in the inactive phase may leave residual functional and cosmetic consequences. Although it's not sight-threatening, they may decrease the patient's quality of life significantly. And a multidisciplinary approach to management remains to be the crucial strategy in the successful treatment of these patients. With that, I'd like to thank you for your kind attention.
Thank you so much, Dr. Ian, for the discussion of the chronic management of. So before we proceed to the next segment of our event, do you have any questions from the floor or from the online audience?
Questions sa Zoom?
Okay. So if there are no more questions, I am tasked also to sort of integrate this session for everyone. So we hope the intention of this session is that it will give our audience a better and wider perspective of thyroid eye disease. So to be honest, I used to think of this condition very trivially when I only read it in books up until I started seeing these patients. So actually, kawawa talaga sila because you will see how significantly their lives have changed. So first, it can really be visually threatening. Pwede silang mabulag. Pangalawa, iba yung itsura nila. Alam nila hindi yun yung normal look nila. And it can be quite depressing for some people. So I think it's hard for us to understand because we're not going through that. But if you put yourselves in their position, it can be really very disabling. So it's really important that we treat them the best way we could, although this condition is still very difficult and a challenging clinical and surgical management to do. No? So these patients are carrying with them a great deal of burden physically, hormonally, mentally, emotionally, and we can offer them the best care if a solid and good collaborative multidisciplinary approach is available to them. So we hope we can offer that in Quirino because a lot of subspecialties can get involved. Like ENT, for example, our IM colleagues from Rheuma and endocrinology, our radiology colleagues who can help us diagnose, especially for equivocal patients that are not presenting classically, and even for those from the rad onco, because as mentioned earlier, orbital radiation is also another treatment strategy for these patients. So with that, do you have any questions?
No questions from the online audience.
We'd also like to acknowledge Dr. Balmero. He's also our part of our team in Quirino for the Urban Binocular Plastics Department. He's here also. If you have any questions, if Sir has anything to say, any questions? See, we have a few questions for our partners.
So do you have any representative from the IM department? Specifically from the endo department?
Maybe online, are they there?
From the floor or from the online?
Good afternoon. This is Dr. Lacetin from the section of endocrinology of the Department of Internal Medicine.
We have just one question for if we have any IM representatives. We have a question. For our IM partners, can you give a rough estimate or percentage of patients in Quirino diagnosed with thyroid disorder with concomitant thyroiditis? And if ever, are we able to recognize and refer them to the ophthalmic department?
Okay. So first of all, I'd like to congratulate the Department of Ophthalmology for a very successful institutional conference. And also, I'd like to congratulate the excellent speakers. So the question is on what percentage of patients have thyroid eye disease? Is that right? Okay. In the US, where they have better statistics, they tell us that 1 in 3 patients with thyroid disease will develop thyroid eye disease. But here in the Philippines, maybe related to what Dr. Yap said, that we are selenium dependent, we see more patients with thyroid eye disease. In my rough estimate, it will be around 2 out of 3 patients with thyroid eye disease. Most of the time, these are only mild cases, and we have very few cases which would have severe proptosis. Of course, if they already have severe eye disease, we refer them to the ophthalmologist. Sometimes we treat them with steroids on our own, orally, give them for around 10 days to 2 weeks, and wait for response. So we do not refer all our patients with thyroid eye diseases to the ophthalmologists, especially the mild ones. We try to treat them on our own. But those with severe diseases really would benefit with an ophthalmology referral.
In relation, sir, with the treatment of management of thyroid eye disease, can you comment on your experience on steroid-sparing agents in patients who have backed out of the use of synthetic steroids and still have active disease? And if ever, what is your usual agent that you find effective and at the same time cost-effective for our patients?
That's really our dilemma also. We only use steroids, IV steroids or oral steroids. The alternatives other than the use of steroids are, as mentioned, very expensive, and it's most likely not going to reach our shores. It's just going to be in the US. And Doctor was right. It's around 300 to 400,000 US dollars for that treatment. So what we do is, because we are selenium deficient, we try to prescribe selenium to our patients, and our maximum dose is around 400 microgram per day. So that's the maximum, but we don't try to reach the maximum because we might result into overdosage of selenium. So that's the only non-steroid agent that we commonly give. And I think it's cost effective because you can buy it from any health supplement store. But I don't have any other, except for immunotherapy, which is expensive and may not be cost effective. It's because it's really not really proven, except for Tepazza or Tepromumab, which has shown 80% satisfaction, even if it's expensive.
Thank you, sir. To our radio partners, what are your most common findings of TED that you encounter among our QMNC patients?
So, good afternoon, everyone. So, firstly, I would like to congratulate lecturers. They're very educational for us on contribution in the treatment and management of TE. Okay, for the question, The most common appearance of EED that we receive in our department is usually the thickening of the muscle belly of the extraocular muscles. And it follows usually our mnemonics na I am slow. Madalas inferior rectals and major rectals, not all the time it is present. It involves all the musculature. And majority of the time, it is bilateral. So as we know that PED is 90% bilateral and about 70% symmetric. The next would be, which is usually the reason for consult, would be your exophthalmos. Okay. So majority of times, these are the only findings that we see in EOMs that we see here in the hospital. Now, sir, only recently have I encountered severe PED wherein decompression was needed. So that was the only time that we saw that there was marked compression of the optic nerve by the thickening of the EOLs.
Can I ask, as a follow-up? So actually, we don't all the time routinely, especially if the patient clinically already presents as thyroid eye disease.
Yes.
But most of the time, this is what I tell the residents. We request for the scan when it's equivocal,
Yes.
or if we want to do surgical planning for this patient. So I think one of the questions is, one of the most common differential is orbital myositis. And I still find some patients who have PED on a CT scan, they look like the tendons are still slightly swollen. Is it like for these cases, and especially those where it's not very clear cut, do you recommend other techniques, or are there other modalities in CT scan where this can be elicited more, that it's just really muscle not tendon involved?
Okay. So thank you for the question. So usually we suggest in CT scan in your typical uncomplicated cases and wherein surgical planning is recommended. So usually yun naman talaga yung recommendation. When you are faced with when you want to know if your treatment, your corticosteroid therapy would work, or if there is a typical representation or equivocal findings, or if you want to assess the optic nerve, MRI would be the diligence. And it is better with contrast, which I will discuss further. Okay. So for these typical complicated cases, you have to think of the usual differential diagnosis, which would involve your orbital myositis, and I think was included in hepatitis and other infectious diseases. So the one of the most sign that would differentiate one from the other, again, as you said, is the tendinous involvement. And we know that there is sparing of the tendons in PED. However, in the acute phase, there are some patients with POD which demonstrates tendinous involvement. Also, in the acute stage, they may also be lacrimal gland swelling. There may be intraorbital fat edema, which is usually secondary to your superior ophthalmic vein compression. No. So one of the things that we look at is, number one, we look at the intraorbital fat. If in some patients less than 4 years old, there may be an increase in the intraorbital fat. This contributes together with your in thickening the musculature, contributes as a thymus, and it points towards CED. Okay. MRI may also show
on the T2 weighted sequences, which is sensitive for edema, it may show increased signal of the musculature. And this would usually tell you that glucose corticosteroids would be effective. In contrast, usually yung TED on the acute phase usually hyperintensive, meaning edematous siya on MRI in the acute phase. While in your, I guess, yung inactive, prolonged, chronic stages, low T2 signal siya, which means that it is fibrotic. Okay. In contrast to orbital pseudotumor, the musculature may demonstrate low T2 signal, which would represent fibrosis, even though there is pain and activity. So that would help us say, bakit ganito yung presentation now? When it looks chronic, of course, the graph that we showed earlier, there's overlap between both of which. So that together with enhancement, so your contrast will also help you. How? In inflammatory or orbital myositis, there is moderate to extensive enhancement of the musculature. However, in TED, or your orbital thyroid ophthalmopathy, there may or may not be enhancement. So those are the things that help us differentiate. Now, aside from this, yung MRI contrast would help you identify kung meron mas, may subcutaneous abscess, if the inflammation diffusely involves all the orbital structures. So aside from that, of course, we think na usually symmetric, usually bilateral, yun yung mga things that we consider. So lastly, for complicated or atypical or equivocal presentation, and if you want to evaluate the optic nerve, you go for an sa compression, not CP if you want to compression.
Thank you so much, Dr. Marco Javier, one of our radio consultants from TV. So moving on to our ENT partners, we have also Dr. Peter Quirino, yes. We have a question, sir. So usually, our service would refer to ENT for severe cases warranting ENT co-management. What are the current management options for severe thyroid or retinopathy, ENT-wise?
First of all, we are for the regulation. But fortunately, it is an ophthalmological and endocrine problem. So I think our role is very limited to of course, our role is to actually refer these conditions to you and to endocrine. Since we also see a lot of thyroid and goiter cases. So I think we have to be vigilant, not only if we see the prognosis, but for Graves and hyperthyroidism, we should be able to already refer that. I'm so glad I attended this conference. I learned so much from the lectures. So another role, as you can see, would be to just help the orbit surgeon to help with the decompression immediately. Since we can approach this endonasally and endoscopically, can I replay the video? I'll just show that. It's one short part. So, so as you can see, Dr. Alman showed a short video of the endoscopic sinus surgery. So this is an extended indication of our fast surgery, which is to decompress the orbit from the nose. And it's very interesting in terms of our, it's also very interesting in our environment. There was a question at the back, Dr. Malahito asked me some questions. I will show you the
What's your video?
yeah.
So just play it. So I didn't know.
Yeah. So here you can see I also want to thank our department for getting all the necessary equipment to actually help us with the surgery. So here you can see we use navigation to help us. Although we don't 100% need navigation all the time, but in this case we opted to need navigation. Here you can see in this screenshot the crosshairs, and we could see that we reached the inferior inferolateral orbital wall. So we almost did a 180 decompression of that orbit. So you can see here in the images, you can see the ethmoidal hair cell. So we did FES first, endoscopic science surgery, to remove the ethmoidal hair cells and remove that wall, that thin piece of bone, the lamina papyracea that guards the orbit. And here you can see now the periorbital being already decompressed. You know? So you still have the periorbital there, and you can see some fat peeking out. Now, thank you, Dr. Barulat, for working, for giving us an opportunity to work with you. So here you can see I'm holding the scope and Dr. Barulat's holding the knife. Maybe I could do this, but I don't want to. I don't want to go to jail alone. So the incision is actually Dr. Barulat. So she's incising the periorbital to take the fat out. So you can see, you can just imagine the decompression that's offering this to the patient. Here you can see fat, prolapsing already. So we did decompression from the level of the lacrimal area up to the annulus of Zinn posteriorly. So here you can see the some of the fibers. I didn't know that if you incise once you incise the periorbital, you can still see some what you call these fibers that's holding up the fat. And there you can see the fibers holding the fat. So this has been also incising those fibers also adds to the decompression. Okay, hold on. That's it. Where's hold on? It's the right orbit. And the right orbit's not here. Anyway, on the right orbit, we could see the. Oh, this is already the land. Okay, I just wanted to show the prolapse also of the medial rectus. You can already see the medial rectus. That is actually scary for us here. So I think our role is to help with the medial decompression. So we're gonna be happy to help you with this, but actually we won't be able to. This is not our. We are not the primary doctors here, but we could help you for the severe cases. So thank you.
Can I just add something? So actually, I just want to share that my experience with Doc Major and working well with the ENT has significantly helped us manage our patient. Because I think the collaboration here, what it offers, it will give you an extra step to move forward if you're scared to do that part. Because that's already the specialty of somebody else. So for example, me, if I'm already in the sinus, no? So that's something that's relatively uncomfortable space or parang hindi, I'm not, it's not a very familiar space for me. And then for Dr. Peter's side, or the ENT side, when they reach the orbit, that's when they're also scared. So it gives you that extra level of confidence to proceed with your surgery if you really work well with other subspecialties. So I've always been a proponent of that ever since I got back from fellowship. And hopefully with other subspecialties, we get to do more of these cases. Yeah.
Thank you, po. Before we move on, we have also Dr. Rowell Freeman and the ENT training officer, sir. Thank you for being here, po. If ever you have any more input. Thank you, sir. I would also like to thank Dr. Thomas Lagnatin Jr. for sharing your expertise on the internal medicine side of the management of diuretics. So thank you so much, doctors, for engaging in our very informative Q&A. I hope everyone participated in our lectures because now it's time for our post-test to be facilitated by Dr. Ian.
Mahirap test natin. So hopefully everyone learned something new or supplemented their current knowledge regarding thyroid eye disease after this institutional conference. So now we'll proceed with the post test. So this will be a similar exam as what you guys answered earlier. So hopefully you'll be able to answer more questions correctly. So again, question number 1, true or false? So you can have thyroid eye disease with normal thyroid function levels. So for this, it's true. So we can have the disease even though we are biochemically normal with thyroid function tests. Number 2, what is the most common sign of thyroid eye disease? So as discussed earlier, so it's letter B, lid retraction. So it's a more common misunderstanding than proptosis, yung most common. Based on studies, it's lid retraction. Next, which is not included in the criteria to diagnose thyroid eye disease. So for this, the first 3, immune-related thyroid dysfunction, typical ocular signs, and radiologic evidences as listed earlier in our discussions are all criteria for diagnosing. Letter D, exposure to cigarette smoke is an important risk factor for thyroid eye disease. So number 4, true or false, TB can present with either unilateral or bilateral proptosis. So this is true. So not all cases of thyroid eye disease are bilateral. It can also present unilateral. Number 5, the following are complications of TB when left untreated except. So actually, all these listed are all complications. Optic neuropathy, exposure keratopathy, and diplopia or doubling of vision. Next, true or false, in PED, men are more affected than women. Ano bang sagot? So it's false. Based on studies, women are more affected in thyroid eye disease than. Next, which extraocular muscle is most commonly affected in TED? So superior, inferior, medial, or superior rectus, inferior rectus, medial rectus, or inferior rectus. So the most common is the inferior rectus. So which modifiable risk factor is most consistently linked to developing or worsening of thyroid eye disease? So again, as mentioned earlier, smoking among this listed here is the most consistently linked with worsening thyroid eye dysfunction. That's why we always advise our patient to avoid first-hand or second-hand smoke. The next one is the first-line treatment for thyroid eye disease. Letter A, correct. Systemic IV steroids. Before we proceed with the other management. And then what qualifies as severe thyroid eye disease? Qualifies. So it's letter B. Kasi it's a sign of compressive optic neuropathy already. Thank you.
Thank you, Dr. Elizabeth. Hope everyone is happy with their consent. So, before we conclude the event, I would like to call on the event our chair, Dr. Lawrence said to reward the certificate of recognition for our speakers.
So I'd like to award our speakers. First, Dr. Angelo Parulan for your presentation, for your exemplary presentation and insight shared during the institutional conference, Thyroid Eye Disease, and then presented this statement.
August 12.
12th of August 2024, Quirino for we also have the same certificates for doctors Sobrio, Cancio, and who are online joining us from places. Thank you very much for those very enlightening lectures.
Thank you so much, sir. So that concludes our event today. And I hope everyone enjoyed and learned a lot from today's activity. Let us now call on our outpatient department head, Dr. Shermaine Pide, for the closing.
Thyroid eye disease is indeed a challenging condition wherein multidisciplinary management is necessary. The conference, which was meticulously prepared by our urban plastic and macromold section consultants, we were able to impart some important points in this condition that would be beneficial in the management of our thyroid patients. So on behalf of our training director, Dr. Jonna, I'd like to thank everyone for attending this institutional conference and hope that you have learned a lot from this session. I also would like to thank our OBL section's efforts and biggest partner for the learning experience. Again, thank you and have a good day.
Once again, thank you for everyone for participating, and may you all have a great day.
Can we have a photo with other departments here in the Thank you.
Yeah.